This week on the Physio Foundations podcast, I'm talking to physiotherapist and researcher Mick Girdwood about his research on knee injuries and osteoarthritis and their association with the strength of the hip and knee muscles. Welcome back to the Physio Foundations podcast, where we talk about the knowledge and skills that provide the foundation of expert clinical practice. So today I'm talking to soon-to-be Dr. Mick Girdwood, perhaps next year, if everything goes to plan. Mick's in the final stages of his PhD at the La Trobe Sports and Exercise Medicine Research Centre in Melbourne, Australia. He's working with a number of people that you've heard from before in this podcast, and a number of people you'll be familiar with if you follow sports medicine research. I'm sure we'll be naming them all in this discussion. And Mick's also a practicing clinician, physiotherapist, and we'll get into that and his background as well in this chat. And in this episode, what I really want to talk to Mick about is some of his research findings, and we'll go beyond the title and the abstract and really talk about what he's finding and what the group are finding and the processes that he's using, and maybe some of the parts of that research that you can take and use yourself in the clinic. So it should be a lot of fun. Mick Girdwood, welcome to Physio Foundations.
Thank you, Lee. Thank you for that very kind introduction. And I agree. Hopefully it all goes well next year, but time will tell.
So you're due to hand up in September, if all goes well, September 2024. And I was a September baby as well with my PhD submission. So good luck.
Well, I can follow in such esteemed footsteps as yourself, Luke. That would be good.
So tell us about, we'll talk about your PhD. Let's talk about who you are first. Tell us about your background and interests and what first got you interested in physiotherapy and then research. Yeah,
it's a good question. So I think I probably became interested in becoming a physio when I spent a lot of time at physio clinics, which is probably a familiar story to many other clinicians as well. And yeah, I was injured. I had a fair bit when I was younger. So I had some back issues and some shoulder pain issues related to a lot of sport I was playing, so a lot of water polo that I was playing when I was younger. And yeah, I think it just sort of piqued my interest as an interesting career to think about. At the time, I hadn't really considered anything like it. I was looking at doing design and architecture type subjects and things, and got to the end of school and thought, don't really know what I want to do. Pretty much toss of a coin decision. And luckily ended up where I am now, I guess. So graduated must be 10 years ago now. And initially wasn't too sure when I did the course either, but I've still here now, I guess. So it must be going okay.
See, I think that's an important, that's something that you just threw in there, but that's a really important theme of this podcast, that journey that people go on, especially the new grads and students. And we've made that point many times, that you may not know where you want to go and many doors will open in the future. So it was sort of a toss of a coin thing. You weren't sure if you wanted to do physio, and then here you are thriving in the profession. So maybe just for a second, a bit of an unplanned segue, just talk to the students listening here about that feeling of going from design and architecture, maybe I'll do physio, I'm not sure what the profession is, to building a really successful career. How did that feel in the first couple of years compared to now?
Yeah, I mean, that time of your life, like I went straight from school into university, you've got a lot of uncertainty in your life. And I was lucky enough, I'm lucky to have lived a pretty privileged life. So thankfully, not too many hard decisions, but that was probably one of the harder decisions for me in life, was, working out what to do. And the first couple of years at uni, I didn't really love it, to be honest. I didn't mind it, but I certainly wouldn't say that I enjoyed my university course all that much, and which just added to the uncertainty, really. And I think it wasn't until I probably got out into placements that I sort of started to see, what I was looking for, I guess, or what the enjoyment behind it. And certainly once graduating, getting out into clinical practice, it was, I think the thing that I enjoy the most still today is the problem solving aspect of it. You're trying to help people work through a problem, and that's something I enjoy, not just in a clinical context, but just in other parts of my life as well, I think. So that's the thing that always, I guess, keeps me coming back. But yeah, I think I still occasionally run into people that I studied with, and they're always quite surprised to hear that I'm working at a university or, working in research, because they remember that I wasn't exactly overjoyed with university at the time, but it just shows how things can change pretty quickly, I guess.
And how much you changed personally
Exactly.
from the very young years where you're still developing from a kid into an adult.
Exactly.
And not to make too many decisions based on how you're feeling at that time. Maybe just play through the years and see where you end up. Yeah.
I certainly, I've, given this advice to plenty of my friends and colleagues and things as well. Like, I straight from school, straight into university, straight into working. And it's a cliche, but there's a lot to be said for just taking it slowly if you have the opportunity to, and just working out actually, is that the right thing for you? Or, there's no pressure necessarily to go and chase the career straight away. I think in the medical world, we're surrounded by so many, very talented, highly, academic and intelligent people. And so you can kind of get sucked into this escalator a little bit, thinking you have to graduate as quick as you can to the best career possible. But I think if you're lucky to have that opportunity to think about things, it's great to just be able to step back and go, I might just have a bit of time to myself, or a year off or something like that, which I didn't have, but it still worked out.
But, there's life still ahead of you, and you're a skier as well, and you're
exactly.
a skier.
I'm a skier, yeah.
You're a skier, okay. You're allowed to be on the podcast then, that's fine.
Exactly. No, I'm not on the dark side, yep.
Very good. Yeah. So balancing all those things can happen within your career, but you've been really busy. You've done a lot in those 10 years since graduating. And where we met was in the football club, working in the Melbourne University Blues Football Club. So Susanna introduced me to you, and the club, Susanna was the head physio there for a while, and then you became the head physio. And weren't you a new grad or a student when Susanna first started working there, and she was a mentor of yours?
Yeah, exactly. Yeah, no, that's where I met yourself, obviously, and I met Susanna before then as well. Yeah, so I think I worked there as a student, or worked there as a trainer, and then when I graduated, I was there working as a physio, and then at some point I was head physio for a while, and then now it's funny how life's changed. Now I'm sort of I guess I work in that more mentoring kind of role that Susanna and yourself worked in for me, which is funny how life comes full circle. But I think that's I really enjoyed being able to kind of work with the younger clinicians that are so passionate about everything and have so much knowledge. It's more useful for me. I get to kind of stay up to date with things and learn everything off them as much as it's the other way around as well.
And that was a really, really interesting position to be in there with in that club for you and for me, because we had a team of really good sports doctors, including Peter Bruckner of the clinical sports medicine textbook fame. So I get to rub shoulders with and work with people like that. So we've both been really lucky. So, and then
it's incredible. Yeah. Like so fortunate to be able to work in that environment and to form so many connections, and so many people in the sports medicine community have sort of passed through there, which is probably a credit to Brookie and all his hard work, and everyone else that's worked there as well.
And then you you were a research assistant at the La Trobe Sports and Exercise Medicine Centre, the LASM Centre. Yeah,
so I worked clinically for a few years, I think I only worked clinically full-time for about a year or two, and then just was really lucky to be approached with, this opportunity for a research assistant role. Someone said, look, there's this role going, you might be interested in it. And I'd always been interested in, we always like to chat about best evidence and that sort of stuff. And I like to be as up to date as I could in the clinic. And this role worked out with Jill Cook and Ebony Rao and Sean Docking. So I'm very grateful to them for my very off the cuff start in research. And that was, a long time ago, maybe 2016 or so. And it just started as a couple of days a week, and it's sort of grown and grown since then, basically. I had a little stint overseas working where I sort of took a break from it and then came back, and I've been sort of, full-time research probably for the last, 4 or 5 years, I guess.
So it was an off-the-cuff start to research via being a research assistant. How did you get that? Was it luck? Did you network?
Yeah, well, I mean, I'd say it's a lot of luck. So at the clinic I work with, Matt King, who also works at La Trobe. He's did his PhD in biomechanics. So we used to chew the fat together in the lunchroom, and he at the time had started his PhD, or maybe he was just about to. And yeah, I think they were about to advertise the position, and Matt kindly approached Ebbs and Jill and said, "Look, this guy might be interested." And we basically just tried it out for a couple of weeks, and I hung around for good, I guess.
Yeah,
So
those conversations, in the lunchroom. Sometimes you have those conversations. You think, well, I'm just having lunch. I'm just talking.
Exactly.
But networking isn't always standing at a conference wearing a nice shirt and hello, my name is Luke, and trying to talk to somebody.
Yeah,
it's quite often informal in that way.
Absolutely. I'm a particularly bad networker, and I think I'd say most of mine is always informal. I'm quite bad at, or I don't particularly enjoy the formally going up to people, that sort of thing. I'm much preferred it organic, and it's easy to say that, I guess, but most of my networks have been developed through those sort of conversations. So it's good. Just to be able to chat things through, and you never know what might come up in someone's background or someone's life that you might uncover, and then it leads to something else, as you say.
And then you can see all the people you've worked with in your publications. If you go and Google Scholar and look you up, all the co-authors, really impressive collaboration and team of people. So tell us about your PhD. So what are you doing it in, and what are you finding? Let's start talking about research.
Sure. So look, my PhD is in ACL injuries, it's funny. It wasn't a massive passion of mine necessarily, but we have a lot of projects in the ACL space at the moment. And so particularly interested in muscle strength changes after ACL injury, and also whether there are some changes to people's brain functioning, so sort of the neuroscience side of things. And as with all PhDs, it's sort of shape-shifted over the years quite since we first, conceived these ideas. It's quite different to what it was, as you know, from your experience. But so really looking in at, I guess, some of the longer-term consequences to ACL injury and reconstruction, and also some of the sort of lesser looked-at things.
Some of your papers are directly from your PhD, and others are... You're the second, third, fourth author. So you're working in with other people. And if you're not in research and publishing, but you're sort of thinking about doing it in the future, that's something that's useful to know. Not all the papers you do will be you as the lead author leading the project. So what are some of the roles you've had in some of those other co-authorships? So I'm thinking about the person who's listening to this and saying, I could do this in the future. And they're sort of interested in not just the PhD, but some of the other working with people in the research group.
I mean, I think for me, it's just been invaluable getting the research experience before starting a PhD, because you actually learn a lot of that stuff beforehand. You learn whether it's for you before you sign up to this 3.5 year, journey, I guess. And so, look, my roles to begin with, we're very much, it was anything and everything. So from the most administrative tasks to, really nitty gritty kind of, research stuff. So really quite mundane things, data checking to, all of a sudden, here's some data that we've just got sitting around, and why don't you have a go at trying to fashion this into a paper and that sort of thing. So I've said this to some of the, the newer people that have come on to work with us as well. It's you sort of prove your worth in one thing, and you'll keep getting thrown responsibilities, and all of a sudden it snowballs. So I think it's sort of, and everyone's different. I'd be lucky enough to work with lots of different people. Some people are very prescriptive in how they give you work. Other people are much more sort of open-ended and are happy to let you kind of take on a lot of responsibility, which can work really well for some people. I think it worked really well for me at the time, because it just gave me a chance to try a bit of everything, and it meant that I got lucky enough to jump on the end of lots of papers and help out with those sort of things, which probably set me up pretty well, I guess. But I think for anyone that's thinking about it, there's most of the time, most research teams are time poor and are looking for some help. And if you're willing to kind of chip in and you might not be doing the most exciting work to begin with, but I think in some ways you'll always, it's not, people think of research as, it's this really drab, dull thing, but if you enjoy thinking about things and really trying to work out what's going on in a problem, I think that's a great place to work in that sort of field.
Yeah, you do have to have that curiosity.
Yeah, that's a good word. Curiosity is a good word, yeah.
So you also got a NHMRC, which is National Medical Health and Research Council scholarship, postgrad scholarship, and I got the same one, I think 10 years before you did. So I'm sure that it's become 10 times more difficult to get something like that in the time. But so a lot of how you can get your funding for your PhD actually comes from not just your honours and having honours equivalents in your degree, but also the work in a research centre, so the points you'd get on some sort of a scholarship score that would help you get your funding that pays your bills while you do your PhD. So it comes from a combination of your academic marks, your experience in a research centre, plus your publications. So that would have really helped as well. So you're working for a few years, finding out, like you said, whether you even enjoy it or not, or what areas you're interested in, and then getting those publications as well. And you need, I think, a minimum of a couple of first author papers to get your scholarship.
Yeah, exactly. I think, you're right. Certainly for scholarship, like, our course when I went through as an undergrad didn't have honours. So I couldn't have even done honours. Not that I think I probably would have when I was the headspace I was in at the time. But you're right, though, the first author equivalence and just that experience is what kind of shines through on those applications. And as you say, I'm sure they were competitive back then when you did yours as well, but they are certainly ultra competitive at the moment, especially with the sort of post-COVID environment that's going around. But it's not to say that they're certainly not impossible to get, but you can't, you need a little bit of pre-planning. You can't just walk straight into a PhD and have it all laid out for you, unfortunately, in our field so much.
And that's where those conversations with people who are already in research are really important, and hopefully we're supplementing that a little bit with these podcast episodes, and for people who are curious and thinking about going in that direction, and give you some ideas about the conversations to have with people and what to expect.
Yeah, it's funny. Like when I was a new grad and I was very keen and soaked up every piece of information that I could as a clinician. I used, I'm not a big podcast listener, but back then I used to listen to a reasonable number of kind of clinical or medical related podcasts. And I think that's sort of what piqued my interest in this area. So I guess if you're listening to these sort of things, you might have been like us as well back then. And then that sort of started that curiosity for you.
Yeah. And I've definitely had conversations with Tom Piers-Barlow, who was on a couple of episodes ago. Tom was listening to these episodes and picking up on ideas, and he wanted to follow up on some of them in a Zoom. And I said, well, let's record that Zoom. There's an episode right there. So, so I think it's an important thing to talk about. So let's talk about knees then. So your research interest, your area, your field, it's interesting. You didn't come to the university with this idea, I want to, I see a lot of people with ACLs in the clinic. I've got these questions I want to answer. You came into a group who were doing a lot of knee research, and in many ways that's a lot easier to come in and be open to developing a project with what's available rather than bringing a project in. I guess they're two very different ways to go about it, but either way, you ended up in a knee-related project, and that's my special interest area as well. It's funny. PhD on the ACL as well, so let's get into that.
Yeah, I know. Well, I was brushing through your thesis just the other day, Luke, just to catch up on all of that, which is...
He was having trouble sleeping, and he thought, read a few chapters of this.
Yeah. It is funny, though. Like, plenty of people come into these sort of projects with a real passion project, and it's not to say that I'm not passionate about what I do, but, some people, it's 10 years or 20 years of clinical experience, and they go, I've just been dying to try to find this thing out. And for me, it was much more, I just enjoy the stimulation and the scratching an itch of kind of being curious about these sort of things. And this happened to be the thing that sort of came up. And so I think, knee injury, I think at one point I probably would have said, like, there's too much research in knee injuries. I don't even, I should go and work in something that needs a bit more help. But in many ways, even though it's one of the most researched things in, physiotherapy, full stop, I think there's still so much we don't know. And particularly in the long term, like we think we're very good the early stages post knee injury in terms of what to do. But so many people have such long-term burden after even, simple quote unquote knee injuries that I think there's a lot still to be that we still need to work out. And that's, my thing is one tiny little piece of that puzzle, I guess.
And that's some of Brooke Patterson's research there, thinking about how many people almost quit their rehab early on before they get to their, get the optimized outcomes. So
exactly.
Yeah.
I think in clinical practice, you sort of think we've done a good job when we get people, post ACL, we've done, we managed to keep them in for a good 9 to 12 months of rehab, and we think they're back to whatever they want to do. But that person has to live with their knee for the rest of their life. And for lots of people, they're really happy, but there's plenty of people they're not unhappy, but they're certainly not at 100% function. And for people that are quite young, that's quite a big deal. If you're 30 or 25 or 35, whatever it might be, even if you're older, you've got a lot of life still left ahead of you. And if you haven't got full knee function, that can be quite a big burden for people and quite a big, can really impact their quality of life.
So you're following people over many years, looking at their strength and seeing how strength associates with other outcomes and predicts other outcomes. So tell us a bit about that. So if you focus on your area, there's a hip and knee strength and other variables. So why hip and knee strength important for people with knee injuries and knee osteoarthritis as a starting point?
Yeah. So, I mean, as physios, we love strength. It's of course, it's really important for your movement quality, movement function, ability to do your task, particularly if you're playing sport, that sort of thing. We know it's so in non-traumatic knee OA, so people that just develop knee arthritis without an injury or incident causing it over time, we know that it's linked to worsening arthritis. So if you're weaker, your joint structure becomes worse over time. And so, of course, that would make sense that is the same in post-ACL space as well, although it's probably a little bit less clear there, which is sort of surprising as well. We know that people develop arthritis much earlier and much quicker post-ACL injury. And so muscle strength might be one of those factors that influences that. And hip strength in particular is obviously something that in knee injuries, looking at the patellofemoral pain world is a very big, part of people's rehab and their goals. And so same in the ACL space. And, I've been lucky to take on a project from yourself and Adam Colviner started almost 10, 11 years ago now. And we're looking at some really longer term follow-ups of people after ACL injury. So we've been able to get some really nice long-term outcomes and trying to see whether some of the muscle strength that way back, 10 years ago when these people first had their injuries at all related to their longer term outcomes.
Which is an interesting question. The more you think about it, the more interesting that is. Strength is something that can change so quickly. A point in time measurement of strength provides an indication of, well, really how strong they are 10 years ago or more.
Yes, exactly.
And yet you found some strong associations with where people end up in the future. Talk to us about that.
Yeah, so we published a paper, I think it's last year or this year, I'm kind of losing track, but looking at whether hip strength, specifically the hip rotation strength, so internal and external rotation, and whether that was related to longer term outcomes, so up to sort of 5 years post-operatively, whether their knee symptoms, their knee joint structure, so measured on MRI, and also their knee function and how that was sort of all related. And interestingly, we did find, a modest but a relationship between their weaker hip external rotation strength and worsening knee symptoms, and also worsening knee tibiofemoral structural outcomes. So if you were weaker, you were more likely to have a worsening knee joint, if I guess. And that's interesting because no one's really looked at anything like that in the ACL space before. There's only a couple of papers in knees in general that look at hip strength and long-term outcomes. And so, it's a cautious finding to begin with, but it certainly suggests that maybe there's some sort of, that might be one part of the picture for some people. But it's interesting, you mentioned that sort of a moment in time thing, and you're right, that was just one moment 1 year ago. And so maybe those people, were still going to be continue to make gains in their strength, or they might have just had a particularly nasty injury that slowed them down. So you're right, it's just one moment in time that doesn't tell us the full story of a person necessarily.
But that's what you do. You measure things and you make decisions or give people advice on what the most likely outcome will be if they don't change that.
Exactly.
And it may well be that, if you get to 12 months after an operation, you haven't yet returned to your previous level of sport, and you haven't developed the strength that you could have developed. That's something that trait is going to play out over time as well. So it's not feasible to be measuring people's strength every 2 weeks for 15 years and then tracking that. But it's just interesting to see how you could get those relationships playing out over decades.
Yeah, and I think that the change over time is another thing that's really interested me. So we have a Whopper group of systematic reviews at the moment that are sort of under submission, looking at change in strength over time. So there's been hundreds of or thousands of papers published that report strength after ACL injury, and we've tried to sort of summarize them all and go, look, this is how strength changes over time. Not just, traditionally in a review, we'd say it's either weaker or it's stronger, or there's this effect size or there's that effect size. We're trying to go, okay, it starts here and it actually, at 1 year, there's these massive deficits. And actually, even though there's less data in the long term, but 5 and 10 years, it's, quad strength is still really reduced. And so they're suggesting there's some really permanent changes. And so we've got a review focusing on non-thigh muscle strength, so hip and calf strength. And then we've also got one focusing on quad and hamstring strength, which will hopefully come out sometime early next year. And some really interesting stuff in that as well, which the hip strength is interesting as well. Like something that as a clinician, I'm sure, I think I probably asked you this at some point, if you ask the average person, I think, would you expect someone post ACL reconstruction to have weaker hip strength? And I think most people would say, well, yeah, we do, and we target it with our rehab. And our review would suggest that actually we didn't find much weakness in their hip muscles at all, measured at that kind of classic 6 month to 2 year time point, which goes against probably what we would expect, and certainly goes against what we see in the quads, where we see really big deficits. So it's easy to say that we're doing good rehab, that's why they're not getting weakness, but I think it's more likely that perhaps actually it's less present than in other conditions potentially.
And so hip rotation strength measured clinically with a handheld dynamometer or with isokinetic dynamometers?
Yeah, so I think hip strength is usually measured with the dynamometer. It's pretty hard to set up you can set it up in an isokinetic dynamometer. I think in Australia, we don't have so much access to isokinetic dynamometers as perhaps in some other countries where clinics operate out of university hospitals and those sort of things. But yeah, I think it's really, there's lots of great papers out there now on great ways to measure hip strength with a dynamometer. The most important thing is to make sure that everything is as standardized and stabilized as possible. So using seat belts and things to stabilize all the contributing movements to it. But so in our study, we used hip standard dynamometer that's easily available to measure hip strength in the very common positions of the hip at 90 degrees of knee flexion, and I think that's pretty useful.
Also sitting, belt, and then applying pressure through the just above the ankle.
Exactly. The other way you can do it, of course, is in supine. So with the sort of stabilizing the thigh with the hip at 90 degrees, which you can see a good demonstration on in one of Joe Kemp's articles on hip dynamometry. But I think there was a recent review actually that summarized a lot of the reliability, what the most reliable positions were. I just can't think of the author at the moment. But as long as you're doing it consistently to yourself and to an established protocol, it's a pretty useful way with 5-10% measurement error, which is pretty good.
And just as long as you understand the measurement error associated with the position you're in and your technique. And to me, it's not just the position, and it's not just the fact that you're using a device and getting a number. A lot of it comes down to your preparation of the patient. We've done a whole episode, Scott Morrison, not the PM, the physiotherapist. Scott and I did a whole episode on setup for dynamometry, which listeners can go back and listen to. But
I should probably go and listen to that myself. But as you say, it's really important how you set everything up. And if you're doing a max strength test, it's important that you maximally encourage them. It's one of there's a whole field of research dedicated to how to do a strength test, basically, and how to actually ensure that it's the max test. And so you want to make sure that you're really encouraging them and really making sure that you're able to match their force. That's probably the biggest limiter in most handheld tests, is making sure that you can match the force that they're producing. Luckily, the hip muscles are not so strong that we usually don't have too much of an issue with that. But if you're testing things like the quads and hamstrings, these are pretty big, strong muscles. The setup there is super, super important.
What other outcome measures could we suggest for clinicians who are not in a research group and they're not collecting data for research studies, but they want to really improve patient outcomes? They want to really track things well. So patient-reported outcome measures. So we've mentioned strength. I mean, we could pick these from the studies that you found have been important. So what would you suggest for someone in the clinic who's getting started and setting up and wants to routinely measure things?
I mean, it's sort of an annoying answer in a way, but it's what's important to the patient. So for some people, and I've done this. Even recently in the follow-up study, we do a lot of hop tests, for instance, because that's what's traditionally done in the literature and it's commonly recommended. But I had one of the patients come up to me and say, "I don't do any hopping ever. I don't know why we're doing this test." And you have to explain to them, and you say, "Well, this is because that's what we do in this research study." But for some people, that might not be relevant, and so I think it's a case of really working with that patient and understanding what they're wanting to do, what's important to them, what their problem is. And so if their problem is not being able to play sport, then, your various hopping and tests, different functional tests could be really important. But even then, if the sport doesn't involve anything to do with those movements, then it's probably less useful, I think. I think, as you say, patient-reported things are really important. So again, asking, for a patient's goals and whether they feel like they can achieve them. So even things like the patient-specific functional scale. I think we're reasonably good at asking about goals as physios, but we're not so good, I think, at being really specific and then measuring back against it. In 6 weeks' time, let's actually check back. Can you do this particular specific thing that you mentioned? And I don't think, and obviously then, I don't place too much importance on imaging and those sort of things in these patient groups yet, because I think it's probably, A, it's not so easy to access for most people, and B, it's important, but it's not the only story. I think focusing on what the patient finds the most important is the key thing.
Yeah, and a really interesting point there about hop tests as an example. A hop test for a skier. I mean, I don't know. Any test of capacity is going to give you information, and it may be that from doing that hop test, if you can't do it, potentially there's reasons for that. Is it strength, power? Is it pain, instability? It's something that's very demanding. Could really give you information, but a nice chance for us to step back and think, well, what's important to the person? What's important to the patient as well when you're planning this out and
I
rehab.
think at the same time, when we get patients in for sort of repeated follow-up studies, or we've got a large randomized controlled trial that I'm lucky to be a part of at the moment, and we use hop tests in that as well, and patients in that tell us that it actually helps keep them motivated, because they want to, people are inherently competitive as well. So it's not necessarily always just about the collection of the data for your decision making. It can actually be a way to motivate the patient as well, because I see that I did crap on this score, or my right leg is not as good as my left leg on this score. So I'm going to use that as a motivator, because, the other key thing is the challenge is to get people to do their rehabilitation and to do all the things that we think is the best for them. And so that might be a way to get them engaged. But you're right, hop tests are still really useful. I think it's important to test in different planes if you are going to do that. So just a forward hop is not going to really be enough, I don't think. You need to test in, a vertical and some sort of lateral hop is good. But as you say, for a certain type of person, it might not be necessarily the best. So think about other options as well. I think I would say is that hop tests don't tell you about strength. They tell you a little bit about strength, but they're not actually as well correlated as we would think, because, it makes sense. They're quite different movements.
And potentially not a linear relationship. It may be that you get enough loss of strength that then it's impacting your physical performance as well. We always assume linear relationships between things.
Exactly.
It's the easiest thing to conceptualize in your head. This goes up, the other one goes down. Let's keep it simple. When one goes up by 1 unit, the other one goes down by 1 unit. But in reality,
especially I think in those tests, you're right. The people that are particularly bad, they're particularly weak, will perform particularly badly on the hop test. That's not a surprise. But a lot of the time we're using these tests at, say, the later end of their rehab, when most people are doing maybe okay. So they're up at, deficits of less than, 15, 10%. And so at that point, the relationship is much more unclear. There's lots of other factors going in. It's their movement confidence, it's their all sorts of different things. And so I think at the lower end, it's a good indicator, I think, maybe it's an okay indicator of those different relationships between different outcomes. But at the upper end, it gets much more murky, unfortunately. And so I think when in doubt, just test the actual, if you want to know about strength, test it. Don't assume it from another test.
That's such a good point. And that we see that a lot just I don't really say just in the clinic, but it's all through physiotherapy, really. This assumption that someone is moving in a certain way, therefore you're weak there. No, go ahead and test it. Yeah, it's just a hypothesis until you've tested it. Yeah.
And hip strength is another example. So we were quite surprised in this review to find that perhaps there wasn't so much hip weakness present. And so we're not saying throw all hip rehab out the window, because there will be some people that will be still really weak in their hip abductors or their whatever it might be. But you just need to test that specifically for that person and go, okay, yep, they are weak here. I'll prescribe them this particular thing. Or actually, no, you're really strong in your hips because X, Y, and Z. Let's save that time and I'll dedicate it to something else. And I think it's easy in ACL rehab is one where it's such a long time. There's a lot of approaches. There's almost, I won't say a recipe, but there's certainly some established protocols where you can sort of just follow the step-by-step approach, which is definitely useful, but you want to tailor it to what the person needs.
Here we go. If there's one take-home message from this end of the conversation, it's think about what's important to the person and what they need, and base your rehab on what you can assess and what the person needs. Yeah,
and I think the other reason I think that's important is when it's not working, is you then can go back and measure and go, okay, well, actually we didn't improve this thing. We didn't improve your quad strength despite the last 3 months of training. Okay, well, we need to go back to the drawing board. Or no, actually your quad strength is heaps stronger, but you're still really suffering. Okay, we need to look at a completely different thing. It kind of helps guide your clinical reasoning to understand why has something worked, which will then help your next decision, I think.
I mean, there's arguments for doing less measurement as well. And,
exactly.
There's lots of reasons for that. And so we're often pro measurement, especially people like you and I who come from a research background and still have our feet in the clinical area through education or through practice. This sort of agenda of let's measure things really well and track outcomes. And then you've only got a certain amount of time with the person as well. So
absolutely,
whenever you can, make your assessment a part of the management, can be a really good thing. So you mentioned using a hop test as motivation. There's also a training effect happening there. As you're hopping, you're going to improve. The reason you do at least 3 practice trials before you go, and you do at least 3 trials, and unless you're getting better and then you do another one. That's the standard protocol for hopping. The reason you do that is because you improve as you're doing it. So there's a training effect and motivation. Confidence will build with Mick there as my physio telling me, hey, it's okay. It will be a little sore, but look, you're actually going further each time. I probably may not have figured that out on my own, just doing some training at home. So there's more to it than just the physical.
100%. I think a lot of even muscle strength training, I think a lot of the time, probably we're actually not doing that good muscle strength training with our patients. They're doing something that's having an effect, but it could be a lot better. But it's still getting them better because I think in a way we're doing graded exposure to things. We're helping to expose the person that's got this problem or this barrier to them. We're exposing them to new things. It's helping them understand that they have the capacity to do something. And so again, that's where that language around how we explain everything and how you nurture someone through that process is really important. And so, it's funny, the more I spend looking at muscle strength and function, these things, the more I think, is it the true muscle change that's doing this, or is it some other non-specific thing? Is it the grading of the exposure, the just getting them to work harder and slowly they will be able to do more and more versus actually a physiological change? I don't honestly know anymore.
Interesting, isn't it? There's so much more to it than muscle fibers, actin and myosin, cross bridges and things contracting. There's a person there who...
it's not to dispute those things, but it's still, that's not the only thing.
Yeah, that's really good. Any final thoughts, Mick?
Oh, look, I think it's interesting you mentioned about not over measuring. I agree. I think even though I work in a background where we measure everything to an inch of its life, elite sport is a good example where these days everything is about measuring everything in 100 different ways and getting as much data as you can. But I'm a real advocate for just getting a good couple of simple outcomes so that you can be confident that it's true and that they're not biasing each other. You're not starting to, if you do too many tests, the fatigue from one will start to influence the next one, and all of a sudden that's a problem. So I think just choosing a couple, being really simple is I guess what I'm trying to say in a really non-simple way. But there's no need to overcomplicate. I think we overcomplicate a lot of stuff. And so I think if we can just pare it back, do a few simple things well, that will often be better than throwing the kitchen sink at something.
Yeah, well said. Well, that's a really good start. I hope we can talk again. Next September, hopefully, if all goes well, you'll have a thesis handed in. You'll have all your final.
It's on the record now.
Yeah. People in the meantime can look at your papers. As you were talking about your hip strength 5-year follow-up paper, I had that one open. It's open access, and so you can sort of even. I've gone off making really detailed show notes. I don't know how many people look at them. I certainly put the timestamps in as I edit the episode so people can sort of flick through, and that's the section where Mick was talking about this and they can go back to it. But you can easily find all of Mick's research with a quick Google Scholar or PubMed search. So I encourage you to do that and have a bit of a look at all the great work that he's doing and his research group are doing. But Mick, thanks for coming on and sharing some of your insights with us today. We'll have to do it again.
Really appreciate that, Luke. It's really think it's a great way to kind of bridge the medium between research and into the clinical world. And I think reaching out through whatever channels, like you can always send me an email. I think these are those informal things that we spoke about at the start of the episode. So very happy to chat if anyone has any questions about anything or is just curious about getting involved or anything like that.
I've gone off dobbing people in for contacting you. The old question of where can people find out more about you and your work and how can people get in contact with you? Sort of wait for people to volunteer that now. But there you go. Very generous. If you want to chat more to me,
old-fashioned email is probably the best for me, I think. I'm not a big social media user. So, always happy to respond to an email.
There you go. His email's sitting right there on the La Trobe site if you're interested. And you can always go and track Mick down and have more of a conversation, just like the one that you had with Matt King in the tea room prior to your even coming on as a research assistant before your PhD. It sort of starts with curiosity is a key word from today, and thinking about your shared ideas, and it's often the less formal conversations like the one we're having now that can where a lot of info can come from. So yeah, thanks again, Mick. It's a great conversation.
My pleasure. Thanks, Luke.
So just remember, if you got this far, you probably enjoyed it, or at least you fast forwarded to here. Maybe you enjoyed parts of it. If you found this conversation helpful, please share it. You can follow Susanna and I at Periton Physio. By the way, Susanna sends her regards to you, Mick, and to all the listeners. She's in the pain cave at the moment, finalising her PhD thesis.
We'll fish her out of there soon.
Yeah, she'll come out of there and get her some sunlight and some healthy food, and get her back to normal and get her back on the podcast. But until then, you can track me down at Periton Physio or at Luke Periton, and we can look up Mick on the internet. So until next time, this is Mick Girdwood and Luke Periton wishing you all the very best with your studying, professional development and lifelong learning.